Douzgou Houge. She's a senior consultant in clinical genetics and has extensive experience in rare genomics syndrome diagnosis and management from previous positions in Italy, Greece, and England. She holds an FRCP award from the Royal College of Physicians, London. She's part of several international networks on rare diseases. She is co-organizer of European and international syndromology courses and conferences. She's a member of the Education Committee of the European Society of Human Genetics and of the Professional Advisory Board of the Myhre Syndrome Foundation. She completed an MD with honors in medical genetics in La Sapienza University Postgraduate School in Rome. She has a master's degree in healthcare management, and she was awarded a PhD in dysmorphology services by the Medical School of the University of Athens with distinction. She was consultant in medical genetics at the Manchester Center for Genomic Medicine until December 2020. And she acted as the developmental disorders team lead for the Manchester Center for Genomic Medicine and Education and Training lead of the Northwest England Genomic Laboratory Hub. In 2021, she moved to a senior consultant position in the medical genetics department of the Auckland University Hospital in Bergen, Norway. Please welcome Dr. Douzgou.
I would like to thank the whole organizing team about the opportunity of speaking to this audience today. I have learned so much already, and I am delighted to be joining you. So I have been asked to talk about the gastrointestinal problems, and those include feeding problems, but also about the clinical experience of seeing individuals growing up with Myhre syndrome. I'm a doctor and my specialty is in clinical genetics. I have been seeing individuals with Myhre syndrome for the last 5 years. As geneticists, we may see affected individuals at different ages or stages of their life. My role has been mainly that of coordinating the multidisciplinary care of my patients and liaising with doctors of other specialties to decide on best approaches for management and treatment of different aspects of this condition. So here I included a few disclosures about myself that, however, have been, I think, entirely covered by the long and very, very polite introduction about me. So thank you very much. So my talk is actually organized in two different parts. In the first part, I will talk about gastrointestinal and feeding problems with a mention about duodenal atresia and pyloric stenosis. However, I will mainly concentrate on the aspect of severe constipation, which affected significantly the first individual with Myhre syndrome I saw in my career and who actually brought me to be part of the extended Myhre syndrome family today. In the second part, I will touch on aspects related to growing up with Myhre syndrome, and that is growth and puberty, but also learning more about the adult clinical presentation of the condition. We just heard from Professor Brunetti-Pieri that Myhre syndrome is a rare condition that affects connective tissue. Connective tissue provides strength and flexibility to structures throughout the body, including the structures of the gastrointestinal system. Myhre syndrome has a variety of signs and symptoms that affect many parts of the body, though not everyone has all the possible features, but I'm sure you know that best than any of us. The features of the condition can range in severity, and some features become more apparent with age. The gastrointestinal features of Myhre syndrome include duodenal atresia, the narrowing of the lower part of the stomach, also known as pyloric stenosis, or of the upper part of the small intestine, also known as duodenal strictures, and also severe constipation. Duodenal atresia is the absence or complete closure at birth of a portion of the lumen of the duodenum, as you can see here in the image. It causes increased levels of amniotic fluid during pregnancy that we also call polyhydramnios, and it also causes an intestinal obstruction in newborn babies. Duodenal atresia requires surgery, and it is usually corrected with a procedure that is called duodenostomy. Pyloric stenosis is a condition where the passage, so what we call the pylorus, between the stomach and the small bowel or the duodenum becomes narrower. The pylorus passage is made up of muscle, which seems to become thicker than usual, closing up the inside of the passage. Both duodenal atresia and pyloric stenosis stops milk or food passing into the bowel to be digested neonatally or near birth, and their treatment is primarily surgical. The surgical treatment of pyloric stenosis is called pyloromyotomy. Most of these procedures are carried out using keyhole surgery, so that means laparoscopically, but occasionally open surgery may be suggested. A number of questions I ask families when I first see them in clinic concern the feeding history of the affected individual. Some individuals with Myhre syndrome may have difficulty swallowing and or feeding. In some patients, this may necessitate placing a tube through a small insertion in the abdominal wall and then directly into the stomach, what we call the gastrostomy tube. The effects of pyloric stenosis, like dehydration due to vomiting, can become serious quite quickly in children, and so often there are no alternatives to the operation. In older children or adults, later onset manifestations may be duodenal strictures and severe constipation. Not to forget what you have now heard a number of times, and that is the very much feared proliferative fibrosis, or the scarring, is an important complication of the condition, and we may also involve the surfaces of the gastrointestinal tract. At this point, please allow me to share with you the story of my lovely patient, as it highlights a number of these aspects. During her pregnancy, there were concerns with regards to polyhydramnios, intrauterine growth restriction, and also decreased fetal movements. The girl was born at 37 weeks of gestation by rapid delivery with a weight of just practically 1.5 kilograms and a little bit more, and also her head size was, let's say, just below the normal. Immediately after birth, she was diagnosed with a pyloric web, so with a type of pyloric stenosis on day 4, because she had persistent vomiting. And that was corrected practically almost immediately on day 5. She was also found to have some congenital differences about the structure of her heart, and that was a patent ductus arteriosus and also foramen ovale, both of which, however, resolved spontaneously, as they frequently do. She then remained small as an infant, and that includes her head circumference that remained on the lower normal range, while her length and weight were slightly better. And by the age of 4 years old, she had manifested developmental delay. She smiled by 6 months, sat unaided by 10 months, rolled over by 12 months, and walked by 20 months. At 4 years and a half, her language could be compared to that of a 2-year-old. However, regarding her early language milestones, we also need to take into consideration that she had also been diagnosed with a moderate bilateral conductive hearing loss. Her parents consented to participate in a project that was then available in the United Kingdom, where I saw her, and that the project was called Deciphering Developmental Disorders. And that was a study that offered whole DNA exome sequencing to patients with developmental disorders, and many of them did not have a diagnosis. So through this study, the pathogenic variant in the SMAD4 gene was revealed, and she received the diagnosis of Myhre syndrome at the age of 3 years. But then, at 7 years of age, she returned to our clinics because she attended the accident and emergency department on 2 occasions, and that was because of a severe and painful constipation. And the second episode lasted more or less a week, with a small amount of hard stool passed on day 5, with 1 episode of vomiting. there was observed some fecal loading, and there was some overflow incontinence. She also had practically lost a little bit of her appetite. Before this episode of constipation, she had loose instead bowel movements, something like diarrhea, that were happening 5 to 6 times a day. She was treated with analgesia for the pain, and she was given Movicol, after which her constipation resolved. In the next few years, she had a few more episodes of constipation, which gradually improved with diet and Movicol. Thank you for sharing me this story. I do think that the stories of my patients and following them through have taught me most, and sometimes this is the best way to remember how is the progression or the natural history of a condition, especially when it is so rare. But at this stage, we need to open a parenthesis and to define what is constipation. So we define constipation as stools that are hard, dry, or difficult to pass. This can make toileting uncomfortable or causing delay or even avoidance to use the bathroom. Sometimes, as in my patient, loose stool will pass around the hard stool, which is stuck. We say someone is constipated when they have one of these three things. They pass stool fewer than 3 times a week. The stools are hard, dry, and small, which are difficult to pass, or they have had an X-ray and that shows stool, and that gives a picture of constipation. Constipation has so far been described in few patients with Myhre syndrome in the medical literature. In 2 patients by Michaud et al. In 2014, although the exact details of these presentations have not been reported. Then another rare condition has been described that is called congenital Hirschsprung disease in a single individual, as well as a case of even rarer massive ischemia, so massive difficulties with the blood of unexplained cause, the blood that goes to the intestine, in another individual with Myhre syndrome who also unfortunately passed away. A single patient with what used to be known as the allelic disorder LAPS was also reported with constipation, and she subsequently developed endometrial cancer, for which she had a hysterectomy, and she suffered life-threatening bowel adhesions, but most probably this was a consequence of the gynecological issues. But why may individuals with Myhre syndrome be susceptible to constipation? For a number of factors. First of all, they can have lower muscle tone. This can make it harder to pass stool. They may have reduced mobility, or they may lack exercise. These aspects are regularly mentioned by families of older individuals, especially when the later onset arthropathy and joint stiffness kick in. A very important factor is the degree of learning difficulty. In fact, difficulties in communication, a vagueness of symptoms, or even ignoring the urge to pass stool are frequent concurrent causes of constipation. Fourth, simply the management of other problems in these individuals is prioritized at the expense of constipation. And finally, we need to remember that an individual with Myhre syndrome may have constipation linked to factors independent of their Myhre syndrome variant, and asked about specific elements like we would in any other individual with constipation. And that is, for example, if their diet is low in fiber, if they are on taking certain medications, or if they have other medical conditions. And in this case, I would specifically mention an untreated hypothyroidism. So a special mention for constipation in individuals with learning difficulties or with a genetic syndrome that includes learning difficulties. The prevalence, so how frequent the constipation is in children with severe learning difficulties, is as high as 60%, and this is significantly increased compared with how frequent this is in the general pediatric population. Chronic constipation has been described as a significant part of the clinical presentation in patients with other genetic syndromes, for example, Rett syndrome, despite the fact these patients have adequate, so correct fiber and fluid in their food, in their everyday diet. Most affected individuals who have learning difficulties and who experience constipation present with bloating, and they have a significant discomfort, and this obviously reduces their quality of life for both themselves and also for who is caring for them. And especially chronic constipation can be of particular concern as it predisposes the individual with learning difficulties to complications. And here there is a list of very difficult terms, and actually I don't want this to be scary. What I want to highlight is that the prompt and effective treatment of constipation, especially in individuals with a degree of learning difficulties, is crucial. I'm sharing here an internet page, which I think contains useful resources for affected individuals and their families. This is a network primarily for parents and carers of children and young people who have been identified as having a learning disability or who have concerns that they may have a learning disability. And the page includes a number of resources around understanding, explaining, and managing constipation, which possibly the audience of this conference may find useful. In conclusion, we hear increasingly of more individuals with Myhre syndrome who have constipation. It is possible that because this is not one of the cardinal or the more striking features of Myhre syndrome, that it goes unreported. Further observations would be necessary to draw a safe conclusion about how to best manage this. However, as with any genetic condition that may also affect cognitive function, constipation is a symptom that we should be actively asking about, and clinicians that manage individuals with Myhre syndrome should have a low threshold for treatment to prevent complications, but also to maximize the quality of life for the patients and their carers. Overall, and to date, there are no established guidelines about the treatment of gastrointestinal manifestations. This is largely symptomatic, and we could summarize, or it may include the following, which I found very useful using the gene reviews that Angela Lynn has already mentioned, which she put together with Dr. Loy Starr. So minimal instrumentation of the gastrointestinal tract is advised because there is the risk of fibrosis and postoperative adhesions that can be very significant. Endoscopy should be approached with caution to avoid any kind of airway problems, and non-invasive 3D imaging may be preferred or could be preferred. Aggressive management of constipation through dietary means or medication if necessary instead is indicated. So if it is allowed, I would continue also with the second part of my talk, and I will take all questions at the end. I hope this is okay.
Yes.
Okay.
Good. Thank you.
Thank you. So the second part of this talk is about growing up with Myhre syndrome. In this part, I will touch on aspects related to growing up, that is growth, puberty, but also learning more about the adult clinical presentation of this condition. So over the last years, I have noticed how most of the adult individuals and their families tell me a similar story in the clinic. So at this stage, all the effects of the multifactorial growth restriction, which is the main characteristic, one of the main characteristics of Myhre syndrome, have taken place. And in fact, individuals mostly have short stature with a compact body habitus and a normal head size. And in fact, we know that the adult height is expected to be more than 2 standards, let's say, below what is predicted by the parental heights. Also, the small hands and feet with small fingers and toes is usually notable. and the functional effects of this start. And I was very interested in hearing the questions that the audience asked to Professor Brunetti-Pierre, because practically they mentioned all of this. And this is effects on posture, which could be a very distinctive posture with flexed elbows and bending forward at the hips, but also on mobility. So there is a reduced range of motion of large and small joints, which is characteristic and which is is experienced as worse with age. And also walking on tiptoes is common. And this is not a surprise from what we have already heard throughout this day, but we also know that the SMAD4 change affects the growth plates of an individual. That is the areas of new bone growth in children and also in teens. So what about growth hormone treatment and Myhre syndrome? We know from a study by Le Goff in 2014 and by Professor Valérie Cormier there, that growth retardation was present in the great majority of cases. And as I mentioned before, although variable in how severe it was less than -2 standard deviations. Growth hormone substitution was tried in some cases with very different results. 2 without benefit, 2 young patients where the benefit could not still be estimated by the time this was written, but actually we could have asked Professor Cormier there, and 2 with good answer on growth curve. However, generally, we have to keep in our minds that studies in adolescents that suggest that growth hormone therapy may increase the incidence of type 2 diabetes mellitus and insulin resistance. And in fact, this was observed in an individual with Myhre syndrome and who had growth hormone treatment. This is a very recent publication in 2020. And it is something that the authors comment upon. What this means for me is that, as in many rare disorders, we have very little data to work with. And any intervention needs to take place within a multidisciplinary management team. And importantly, talking through the individual and their family about also possible other undesirable effects and how to manage those. The other very frequent aspects are questions around puberty and Myhre syndrome. Puberty has been reported to be normal, premature, or delayed. And again, we have to define what we mean. So according to the National Institutes of Health, puberty usually begins in girls between 8 and 13 years of age, and in boys between 9 and 14 years of age. So puberty is considered to be early in boys before age 8 and girls before 9 years old. And this is what we call precocious puberty sometimes. However, these are also data or numbers that may change over the time. So this is something to keep an eye on. So however, we also need to know is that within Myhre syndrome, secondary amenorrhea has also been reported. What is amenorrhea? It is the absence of periods. Secondary amenorrhea means that someone has had at least one period and then they stop menstruating for 3 months or longer. It is different from not ever having experienced the period. It usually occurs if someone has not had their first menstrual period by age 16, what we would call primary amenorrhea. So a variety of factors can contribute to this condition, and that includes the use of birth control, certain medications, hormone shots, medical conditions such as hypothyroidism, but also what I think has been sometimes mentioned by my patients with Myhre syndrome, being overweight or underweight. However, I would like to mention a very rare observation. One of my patients presented with a combination of gelastic seizures and precocious puberty. A gelastic seizure, also known as gelastic epilepsy, is a rare type of seizure that involves a sudden burst of energy, usually in the form of laughing. These are mostly partial seizures with uncontrolled laughing or giggling. They are often called laughing seizures. The person may look like they are smiling or smirking. So if a child has gelastic seizures and precocious puberty, then it is likely that they will be found to have a hypothalamic hamartoma, that is, a rare tumor-like malformation that occurs in a specific part of the brain we call hypothalamus. It happens during fetal development and it is present at birth. These are tumor-like malformations that are not progressive. They do not expand, spread, or metastasize. They grow in proportion to normal brain growth. So they grow as the brain grows, and consequently, the relative size to the rest of the brain usually is the same for the lifetime of the patient. There is a great variety of type and severity of symptoms from patient to patient with a hypothalamic hamartoma. However, in the overwhelming majority of patients, the symptoms are present during childhood, and this is something that is diagnosed early. In my patient, serial brain imaging and a correlation with the symptoms was the adopted approach. This is mainly because the lesion appeared unchanged in terms of size over the years, and the symptoms did not progress or change. On the other hand, there is a very diverse range of possible effects with this condition, and it definitely requires multidisciplinary management, mostly by endocrinology, neurology, or neurosurgery. So if you are aware of affected individuals, consider contacting us, as we would like to understand more about this possible rare complication in individuals with Myhre syndrome. And at this stage, I could not mention the contribution of Angela Lin regarding women with Myhre syndrome. All women with Myhre syndrome should have regular gynecologic evaluations as part of their routine care, and especially if they have early onset of puberty and or these very heavy periods that have been mentioned during the day. So clinicians should assess risk factors for endometrial cancer, and that is an early onset of the period, polycystic ovary syndrome, obesity, but also a family history of cancer, which of course is independent. In the last few years, we came to know about this very rare family with more than one individual affected with a condition. Here, the group of Bert Calvert, who already spoke to you, reported the first of what we call familial recurrence of the condition. And they tell us the story of a lady with Myhre syndrome who gave birth to two affected children with assisted reproductive treatment. So Myhre syndrome patients may reproduce, although reduced primary fertility is highly probable. And the authors comment that offering preimplantation genetic testing could be considered. On the other hand, this observation is also a reminder of what is the recurrence risk of an autosomal dominant genetic condition like Myhre syndrome. Myhre syndrome is inherited in an autosomal dominant manner. So this means that affected individuals have a 50% or 1 out of 2 chance of passing their SMAD4 variant to their children each time they may achieve a pregnancy. Members within the same family may have different signs and symptoms of the condition. However, as we grow our experience and knowledge about rare genetic syndromes, I think that also the range of questions grows. Further significant aspects that many of the families and adult individuals have asked me in my clinics are some behavioral issues and how to manage them, the risks and benefits of any type of surgery, but also many aspects of everyday life like mobility and exercise, work, level of independence, and of course, relationships. In fact, in an effort to better define Myhre syndrome in adulthood, and as Bert Calvert already mentioned, we approached clinicians who are part of the European Reference Network, ERN Ithaca, to contact us if they have seen families who consent to share clinical data about individuals with Myhre syndrome aged 18 years old and above. Bert already mentioned some preliminary findings, and I do hope that this will give us much, much more information that we can offer you. So I would like to thank very much the individuals that I have seen in my clinics and who taught me so much, the United Kingdom Myhre syndrome community who had involved me when I was there until December very much in their efforts, John Bassett and Professor Browning-Kerr, who were my small team of people when I saw the first individual with Myhre syndrome, and absolutely the rest of the members of the Professional Advisory Board and my husband. Thank you very much.
Thank you, Dr. Douzgou. So I'm going to start with some questions.
Yes.
The first question comes from a person that asks, have you seen any cases of diarrhea with Myhre syndrome?
So the cases, well, it's not, the cases I have seen with diarrhea, this type of diarrhea that is actually linked to constipation. So, and you know, this is why I told you the story of my patients, it is difficult sometimes to make a distinction. However, in the cases of diarrhea linked to constipation, the constipation became very apparent after a while. So what I mean is that if you continue experiencing diarrhea and not constipation, I would not be certain this is constipation, but in any way, you definitely need to mention it to your primary care physician.
Okay, thank you. Have you heard of other patients with episodes of intermittent painless rectal bleeding with no constipation?
No. And has that been investigated? It's not, sorry, I thought I could also ask questions. I'm sorry. So no, I haven't, but this needs to be properly investigated. I mean, sometimes people with, it depends on the type of bleeding, and sometimes people who have chronic constipation, they can have that as a complication, of course. But if it is mentioned, I heard rectal, which most probably means it is linked to constipation. So this needs to be investigated. So again, primary care physician, they need to do some standard exams. But if they do find that the cause of this intermittent rectal bleeding is constipation, then you know, the management could be very easy.
Sure. Okay. Can you comment on long-term use of Movicol in people with Myhre syndrome?
Yeah. So you see, I have, let's say, I have experience of long-term use of Movicol in different conditions that are genetic and where people have learning difficulties. So I can tell you straight ahead, there's no correlation. It isn't, you know, 1 and 1 makes 2. It doesn't work for everyone. Sometimes it works, and we do not know why it works then. However, I do think it is a good kind of, how do you say, thing to have. So it is good to have a medication here to use, or a type of approach. So I would suggest definitely trying it. And I would say that trying it and also paying very much attention to diet at the same time.
Is there any issue with long-term use?
I think that the reason we are kind of using Movicol is with the hope that it, you know, the kind of this will become a more normal process. As far as I know, no, but definitely it cannot be used in very large kind of quantities or all the time. So it needs to be moderate. And again, it is based on the experience of the individual, but also on any other comorbidities. For example, if they have any other problems that may cause, you know, a different intake of necessary nutrients from their intestine. So it is very important that this happens under the supervision of a primary care physician.
Okay, good, good. Okay, next question. What is the impact of early puberty medication on the potential for growth?
Yes, very goodness. So, I'm not an endocrinologist by background. So I think this would be best asked to, someone who can explain this in great detail. So it is, so sorry, could you repeat the question to make sure I understood well?
Sure, I'm going to get the original one.
Early,
My child is on medication for early puberty.
yeah.
Will this have a potential for problems with growth?
Okay. Well, it should, I mean, it could, okay? It's a very fine balance. I presume this is an individual with Myhre syndrome who would have had, in any case, consequences on their growth from their condition. So this is a very complex question to answer. I think this question can only be answered by who is providing the medication in this specific patient.
Okay. Have there been studies on the cause of infertility in Myhre individuals?
Well, not as far as I know, not as far as I know. But I think that Lois Starr mentioned before that, for example, there are these very heavy periods and there is like a process of inflammation that keeps happening. I do not think we know, and I think it would be a very important matter to look into, because we will get to know of more and more individuals that are adults or that are let's say younger adults with the condition.
Okay. I'm just reading one more. I think that was it. Any other questions before I say goodbye to Dr. Douzgou? Douzgou, sorry. Getting late. Well, thank you. Oh, can bloating be caused by anything other than constipation?
Sorry, Ken?
Can bloating be caused by anything other than constipation?
Yes. And again, have it looked at. So it's very difficult to answer because yes, it can. But if I do see a patient with Myhre syndrome, an individual with Myhre syndrome, and they have bloating, the first thing I think about is constipation. So they should be kind of looked at.
Okay. All right. I think that's it. Well, thank you so much. That was very helpful and lots of great information.